I invite you all to stand with me and join in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury Avenue. It is also accessible by Zoom. I ask that you mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting, and it will be posted on our website for future viewing. Cheryl, could you take the roll, please?
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Yee.
Present.
Director Epen.
Thank you, Cheryl.
You're welcome.
We now move on to communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Cheryl, are there any written communications?
There are no written communications.
Okay, we'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? None? Does any member of the public want to remove an agenda item from the consent calendar? Hearing none. May I have a motion to approve the consent calendar, items A and B?
Mr. President, I move that the Board of Directors approve the consent calendar, items A and B.
I'll second.
We have a motion and a second. Cheryl, if you take the roll for us, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Yee.
Aye.
Director Epen.
Good, that motion passes. Thank you very much. We'll now move on to our presentations. Tonight we have a budget presentation helpful to all of us. Kimberly, if you'd like to introduce that for us.
Yeah, I'm going to start by introducing our two presenters this evening, and then I'll open with just a few comments. I think many of you know Thomas McDonough. He's our Vice President and Chief Financial Officer, but he's relatively new to our healthcare system. He joined in February of 2023 after working the last few years for 2 tribal health systems in Alaska and a rural community hospital in central Washington. Prior to that, Tom worked 22 years with Providence Health System. For the last 7 years with Providence, Tom served as their CFO of Shared Services and SVP of Treasury. Tom graduated from Washington State University with undergraduate degrees in economics and finance. His graduate degree focuses on business analytics and administration. As CFO for Washington, Tom has accountability for accounting, audits, revenue cycle, payroll, payer contracting, treasury, financial planning and analysis, budgeting, and benefit programs. Tom is an active member of the Healthcare Financial Management Association, Society of Human Resource Management, Association of Financial Professionals, American Finance Association, National Investor Relations Institute, National Venture Capital Association, and CFO Leadership Council, and participates on the District Hospital Leadership Forum. Also presenting this evening is Erica Luna. She's our Assistant Chief Financial Officer. She has responsibility for the day-to-day operations of the Finance Division, including direct oversight of accounting, financial planning and analysis, and treasury. Erica earned a Bachelor's of Science degree in Finance from Cal State East Bay and has many years of experience in healthcare finance, including leadership roles with HCA Hospitals and Verity health systems before joining the district in September of 2018. So before we begin, I just want to say a few words. As you know, we're presenting the budget estimate for fiscal year '24. I think we all know we've experienced some of the most unprecedented medical and economic challenges over the pandemic, and we now are living in really a new normal at this point. But we're also facing many other challenges, both operational and economical. In economics, we're seeing skyrocketing costs for labor, both for staff and physicians, supply costs. We're also been subject to market volatility, and you'll see that with some of our investments that have been impacted. But these are some of the same things that all hospitals in the state of California are facing. We're going to talk a little bit about our road to recovery that we've been on. We have made some very good progress towards that. Things have been slowed a little bit, just given some of these challenges that we've been facing. But we've been focusing on our care coordination and our utilization, along with our revenue cycle. We're also been building our infrastructure in terms of our infill projects for more time in critical care, looking at that phase 3 building, some other capital projects, and also some of our services and programs, especially around trauma. I think we all know that overall this budget will provide for us the financial means that we will, in order to be able to continue to provide the high quality health care for our patients and for the community. So I'm going to turn it over to Tom. He's going to begin.
Great. Thank you, Kimberly. It's my pleasure to present the first part of the fiscal year 24 budget. Erica will take over for a few slides, and then I'll come back, and we'll tag team from there. Slide 2, simple restatement of our mission statement. As a healthcare district, our mission is to meet the healthcare needs of the district residents through medical services, education, and research. Next slide. Kimberly alluded to the healthcare environment. The important takeaway here is that our community continues to receive high-quality care here at the hospital, our clinics, and at our ambulatory surgery centers. Even though we've been forced to deal with the economic challenges that Kimberly mentioned, both on a regional, state, and national level, we're happy to say that we have moved the organization forward, where our volumes are increasing from year over year, and our net patient revenue is strengthening as we move forward. However, as the potential recession looms and economic volatility persists, I don't know how many of you spent the day watching the Chairman Powell talk about the economy and where the Fed is at, but he said it's going to take a number of quarters to see if the constraints that the Fed has put on will be effective, and that he expects the labor shortage and the salary inflation to continue well into the future. So that talks about our large increases in labor costs. The pension and retiree medical plans have exposure based on market performance, and we'll talk about that when Erica speaks. Pharmaceuticals. We are experiencing or may experience shortages in some of our key pharmaceutical medications and drugs, and that also has the effect of lifting those prices. And then professional services and regular supplies. I was going to say, we hope to see a regression back to the mean as it relates to supply costs, et cetera. I think Kimberly was right. We are in a new normal with elevated expenses. I don't think we're going to go backwards. But despite these challenges, the system made good progress on our road to recovery. The management team continues to work diligently, and despite both external and internal adverse situations, i.e. physician departures in key areas like cath lab, which we'll talk about, and the issues that we've talked about already regarding the economy and the local area, we have made some really strong advancements. Next slide. So to level set everybody, the road to recovery, I'm going to take us down to the very bottom. We have made great strides. The overall financial goal of the road to recovery was to bring the hospital and the consolidated financial performance to break even or better. In fiscal year 22, it was to reduce the consolidated losses by 50% by the end of 23, and to achieve break-even results on a consolidated basis at the end of 24. Next slide. Erica.
This slide is the trend of our net operating income going back to fiscal year 20. Fiscal 20 and fiscal 21 were the years that were most significantly impacted by the pandemic. And you can see the significant improvement, as Tom alluded to, in fiscal 22, where we really did see a lot of our volumes bounce back from pre-COVID levels, and overall had a really strong year in fiscal 22. In fiscal 23, we have experienced some challenges, particularly one that you'll hear more about in the pension expense, a significant increase in our expense of over $20 million in the fiscal year 23, as well as in fiscal 24. But you can see that in fiscal 24, we are expecting and budgeting for significant improvement with several initiatives and targets that we've set for ourselves, and you'll hear more about in the upcoming slides. There's it.
Okay.
And the following slide is the net income trend. Same trend as the slide we just saw previously, except that this also includes non-operating income. So that's the only difference of this trend that we just saw. Next slide, please.
So the last two slides were more around setting that road to recovery picture. You saw that 22 was a positive year. 23 is an adverse year. There were some challenges, especially regarding the pension, and we'll get to that in a second. But the tailwinds, the things that really moved us forward, included the work that we are doing on the trauma center. After receiving designation for Alameda County, we're in the process of recruiting the program director and the medical director for trauma, and we have built in for 24 a budget to continue to educate staff and buy various pieces of equipment that are necessary for the trauma, getting ready for trauma in July of 24, excuse me. We started a diversity, equity, and inclusion journey to become a more inclusive and understanding organization, because we are in a very diverse area. It's important that we understand and represent our community. We established the Radiation Oncology Center, or ROC, as a standalone JV, standalone JV with University of California, San Francisco, and it is a hospital outpatient department. We continued work on Warm Springs, the development of the two buildings that we purchased down south a little bit, and are working with UCSF on drawing and finalizing our partnership there. Given the pandemic, though, we did put a number of updating aspects of our infrastructure on hold so that we could focus on the crisis, the pandemic crisis. In fiscal 23, we have moved some things forward, both in technology, policies, practices, and then just redefining what is continuum of care for the organization. We've renegotiated our implants. As you know, we are either 1 or 2 in the state and the country. We're in the top 3 for volume of knee, shoulder, spine, and hip replacements. So we renegotiated the implant costs, and that provided us with meaningful savings going into fiscal 24. We value our clinical and non-clinical staff. We could not provide the care to the community without them. And so it's important to us to provide competitive total rewards. And we live in the third highest cost area to live and the third highest cost of labor area in the country. And so by paying competitive wages, our salaries will see an increase. Initial consolidation of the medical foundation into the Fremont Office Center has begun. Cardiology and administration will move in at the end of June, and cardiology is scheduled to move in August. And then we begin the next phase of the facility master plan. We are completing the bridge. They're preparing to pour the column on the other side, and then will come the actual bridge structure. And we're using the GO bonds that the community authorized us to use to finish that. And then we're moving forward with the design and construction documents for the infill of Morris Hyman. Some of the headwinds that we face moving into '24, population health. There is more and more focus being placed by CMS and some of the other payers on population health, which really focuses on health outcomes, and reimbursement can become dependent on those positive outcomes, not only for the one patient, but the overall community. Disruptive competition. We have had Amazon buy One Medical. We have had Walgreens start their own clinics in their stores. We've had Walgreens buy CareCentrix, and then we had Optum continuing their expansion in this space. So it's not the hospital down the street or 14 miles away. It could be in our backyard in one of these retail locations. Lingering economic issues, I won't belabor the point, but they are lingering, and they are of concern to us. Additional headwinds. Labor market, it is especially tight in healthcare. We all know that, and that is putting a lot of pressure, upward pressure on salaries and wages. The pension and retiree medical funding, we talked about this as a headwind early on in the presentation. We are now faced with an expense, given the market performance of fiscal '22, or in fiscal '22 and '23, of an additional $20 million of expense on for the next 5 years in there, and that eats into our cash flow. Expenses, again, just always trying to control expenses. And we talked about the cost of supplies increasing, Trauma, we said it was a tailwind. It's also a headwind, because we are spending money, but there is no associated revenue with that. And then uncompensated care. It's increasing. It's not increasing drastically, but it is increasing. And so we do want to keep an eye on that. So just to put it in perspective on uncompensated care, the green, or I guess it's dark bar on the left for Medicare and Medi-Cal, are the total costs of the services provided. And the lighter column is what we actually received from Medi-Cal and Medicare. So a total of $152 million is uncompensated care.
I appreciate the pause on that. That's an important factor. It truly is a very, very important factor in the overall financials of the hospital.
Absolutely.
I think very few people understand the difficulty in that area.
Slide, please. There, thank you. Some of the strategic and operational initiatives that have been factored into the budget that Erica will review with you and cover. Drive continuous improvements in quality and safety. Implement utilization and revenue cycle strategies. So we have identified about 4 or 5 key revenue cycle initiatives that have also been baked into our budget for '24. Optimized payer contrasting reimbursement rates. This is a constant management. It's not negotiated and be done until the next cycle, 2 or 3 years later. We have to look at it constantly. Leverage mission-critical technology to enhance the patient experience. We are going to continue, as I mentioned, to invest in DEI, or diversity, equity, and inclusion, because we feel that that is a journey that should never end as we welcome additional people into our community. Strengthen our recruiting and retention across the organization. Implement cost-saving initiatives, including labor productivity, which we will address in a moment. And then implement the next phase of our campaign to refresh the Washington brand. Additionally, we're using this to prepare for the trauma center. Strategic growth initiatives continue. We are focused on the cancer care center and JV. Strengthening cath lab. As you know, our volume was off in fiscal 23 due to a departure of a physician. Another physician has been hired who starts later this year, and we look to return to volume pre-departure in fiscal 24. Cardiac and neuro programs, you'll notice in the volumes that they're a little light in fiscal 23. And that is a focus for us as an organization in fiscal 24. Joint replacement and maternal child health. Capital investments are also in our future as we look to complete the patient bridge and the infill project. We also have the Institute for Research and Restoration, Joint Research and Restoration. We're building out what we call the garden clinic in that space. We're relocating Whitmouth, which we already talked about, which will eliminate, I believe it's 16 or 18 leases that we have over the next year and a half. And beginning to design that phase 3, which is that other building next to Morris Hyman. And I'll stop there and see if there are any questions before we go into the numbers for the budget. Okay?
Okay, on this page, we see the budget assumptions that are rolled into the fiscal year 24 budget. I won't go through each one, but you can see overall we are budgeting for increases across the board in all categories, with the exception of average length of stay, which we expect to see about a 5.5% decrease. And again, this is related to some of the initiatives that Tom highlighted, with the initiatives around quality and safety, really managing our patient stays for the best patient outcomes. Down in the expense section, you can see that we have accounted for the inflation. As it's been noted, the heavy inflation environment, we are expecting to see that in the next fiscal year, and we've outlined those expectations here. One that I will call out is the pension expense. As it's been noted earlier, that is one expense that we'll see here coming in the fiscal year 23. It'll be recorded in June. So we'll experience that in fiscal 23 as well as in fiscal 24. And this is one area that we have not been challenged with in prior years. So during the COVID years, we were impacted by COVID, but we had favorable returns on our investment earnings, which really helped us in those years where there was practically no expense in 21 and 20. That will be a challenge for us in fiscal 24. Moving into the next slide with the fiscal 24 income statement, just walking through high level. There's future slides with a little bit more detail, but here you can see the hospital's total operating revenue is increasing almost 9%, and that's given the increases that we'll walk through in volume, as well as the revenue improvement initiatives outlined earlier with payer contracting, as well as some other revenue cycle strategies that are being implemented currently and expect to materialize favorable results in the fiscal year. Total operating expenses, again, we'll see that detail further, but overall increasing 4% as we do have several initiatives offsetting some of that inflationary pressure that we are seeing. The hospital net operating income is budgeted to be at $15.1 million compared to a projected loss for the current fiscal at $10.2 million. This represents a significant improvement from the current year. We also showed net income, EBITDA, and the net loss for affiliate entities, including the Development Corporation and WTMF, which are an integral part of the system. Consolidated, we are budgeting a net loss of $9.8 million and a consolidated EBITDA of $25.7 million compared to $6.6 million projected in the current year. I do want to call out that we are transitioning in the new fiscal year 24 to using EBITDA, which is more consistent with nonprofit organizations, so that T will be falling off as we present financials in the new fiscal year. Moving into the next slide, discharges. Here's another change that we're moving towards in the next fiscal year. Normally, we would share with you admissions. Admissions and discharges are pretty similar in terms of the numbers. It's just depending on when you count the patient at the point of admission or at the point of discharge. And since some other key metrics like the case mix index for that an average length of stay are only available on a discharge basis, we want to show that more consistently. So with discharges, you can see here the trend since 21. And actually, since 20 has been on an upward trajectory, and we expect that to further increase in the fiscal year 24, given some of the strategic initiatives that we've implemented and the volumes that you'll see. Discharges by payer. And this side, the left side of the slide shows the number of discharges, and the bars reflect the different payer categories as a percent. Overall, the payer mix has held mostly consistent over the years, except for in fiscal 20, we saw a shift since then from PPO to Medi-Cal, and that has maintained over the last several years. Next slide, please. Patient days. Patient days, we can see the upward trajectory that's happened over the last several years. However, it's not as significant as the increase in discharges, and that has been due to a lot of the work in quality and safety around average length of stay, which you'll also see in the upcoming slide. Average daily census, similar trend as patient days, upward, and we expect that to continue upward in fiscal 23 or 24. Outpatient observation days, here the trend reflects an upward trend in 21 and a peak in 22, and we have seen decreases since. We are on track to see about a 15% decrease in 23 compared to 22, and expect to see a further decrease of about 3% in fiscal 24. This is due to all the work being implemented, again, around quality and safety and getting patients into the most appropriate level of care, depending on the patient's needs. Average length of stay, as I mentioned earlier, back in fiscal 20, we did have a lower average length of stay, and prior to that, length of stay was lower when more of our joint cases were done in the inpatient setting. They drove down the average length of stay as they only had a couple days stay for the most part. Since those have transitioned to the outpatient setting, we did see that spike in 21, and we've seen it continue to drop year over year, and expect it to further decrease in fiscal year 24, again, with the work being done around quality and safety. Deliveries. Deliveries have been impossible to predict and very volatile month over month, but we have seen a steady uptick in the last few years, and we do expect that to continue in 24. Surgical and cath lab cases. We have combined these, this year, so you can see the surgical or operating room cases are reflected in the blue, and cath lab cases are reflected in the green bar below. Surgical cases, including endo, have been on an upward trajectory over the last several years, even with the outmigration of cases to the ambulatory surgery setting, which we'll see more clearly in the next slide. We are still anticipating further growth of about 2.2% in the fiscal '24. For cath lab, as mentioned earlier, we did see a significant decrease from '22 to '23 due to physician turnover. We have had significant recruitment efforts this year, and as Tom mentioned, we will see a couple of new physicians starting in the next few months, and we have projected that growth in our fiscal '24 budget of about 20%, which brings us much closer to the fiscal '22 levels. This slide here shows the breakdown of the different categories of surgical cases and cath lab cases, and you can see, as noted earlier, all surgical cases are expected to increase with the exception of joint replacement and other surgical cases, where we are expecting to continue to see outmigration of cases to the ambulatory surgery center. But even in that category, we are seeing growth in our shoulders program and some of the newer physicians ramping up. It is just masked by that decline going into our joint venture. Again, in the cath lab down below, we are expecting a growth of about 20%. Next slide, outpatient visits. Non-ER outpatient visits have been on an upward trajectory since '21, and they are staying pretty flat from fiscal year '23 to '24. Again, the thing that's a little misleading there is that we are projecting a decline in the COVID lab visits due to the regulatory changes that have happened recently, and that is masking the growth that we are expecting to see, particularly in our infusion center and our radiation oncology center. So that's a little bit misleading there, but emergency room visits have been growing significantly in the last couple years, and we expect that growth to continue into fiscal '24. Labor productivity indicators, total paid FTEs, we see going up about 2.5% or 40 FTEs. Much of this is our labor force is variable, directly related to increases in volume. So a lot of that growth is coming from the volume increases that we are budgeting for. And we also have some investments in new programs. As Tom mentioned, we have about 12 FTEs here for training and educating our staff. And we won't see any revenues offsetting trauma in this fiscal year, but we will see that in the upcoming fiscal year '25. Radiation oncology, new program as well, and then some new positions for infrastructure improvements that we are investing in as well. The next slide shows hospital revenue. Going up to total gross revenue, increasing from the projection to the budget at almost 6%, directly related to the volumes that we've just walked through. And you will see that our net patient revenue, after contractual allowances and provisions for bad debts have been applied, is going up 8%. That delta reflects all of the important work that's been happening with payer contracting, improving our reimbursement, as well as the revenue cycle improvements that have already started in fiscal '23 and will continue to see results in fiscal '24. So that is reflected in our budget, bringing us to an 8% increase in net patient revenue in the upcoming fiscal year. Other operating revenue, this includes some of our other non-patient related revenues, such as cafeteria, pharmacy, and supply rebates. The big increase here is another initiative that we have implemented with the 340B pharmacy retail program. We have started that as of January of this year, and that is really driving the growth from the projection to the budget. in other operating revenue. This brings our total operating revenue for the budget year to $593 million, an 8.8% increase over the current year projection. Hospital net patient revenue trend, see on this slide, but it is increasing steadily year over year, and highlights the 8% change that we discussed with the ongoing initiatives. This slide here outlines the different categories of expenses. As we've noted, labor continues to be a significant cost for the organization and growing due to volume growth, wage inflation with all of the retention and recruitment challenges and initiatives that we have invested in. Employee benefits, it doesn't reflect much of an increase, but that is because we have that $20 million expense reflected in both years, and expect that to continue over the next 5 years, dependent on investment performance of our pension plan. The other items here are mostly increasing due to inflation, and the volume changes that we're making. And also, you'll notice that depreciation is decreasing with some of the existing items falling off of the depreciation schedule, bringing our total operating expenses to $578 million, or a 4% increase over the current year projection. The next slide highlights our earnings before interest, depreciation, and amortization. As mentioned earlier, we are dropping the T for taxes. As a nonprofit organization, we don't pay income taxes, so in the new fiscal year, we will be reporting EBITDA. And for the budget year, that represents about $52 million compared to a projected $34 million in the current year. Next slide. This slide shows a summary of non-operating income and expenses. Investment income, general obligation, property tax revenue, interest expense. We do not budget for gains and losses on investments, as we've noted the market volatility. So we are projecting or budgeting for $4.2 million non-operating income in the fiscal 24 compared to 2.2 in the current fiscal year. This next slide outlines our capital spending for the current or for the budget year, fiscal 24. It's important to note that these projects, the total project amount is not reflected here. The amount that we expect to spend in the fiscal year is highlighted here. The new capital requests are outlined, including some of the initiatives mentioned before with Warm Springs build out, that phase 1, the beginning of our phase 3 design plan, the cancer and infusion care redesign as we expand and grow that service line. We have capital investments earmarked for that. The Morris Hyman infill project that we mentioned earlier, tenant improvements, urgent care, and other routine capital equipment and projects. There are also a few committed capital that we've already started working through in the current fiscal year, and those are noted here as well, bringing the total for capital at $43.3 million for the current year. We've also outlined the funding sources that will meet these capital investment needs. And the next slide just gives further detail of the routine capital projects and equipment that is included in the previous slide.
That concludes our presentation on fiscal 24's budget.
Thank you very much. I appreciate how well you presented that. It's very informative, helpful, exciting. Are there any questions or comments from the board on that?
I just think it's important that the public understand the depreciation expense, which is a non-cash expense, which goes along with building all the new facilities that need to be built. And I'm glad that you're isolating that and demonstrating the EBITDA and the amount of actual cash that is being produced by the district.
Sincerely, thank you for that. We understand the tremendous amount of work that goes into that, from you, of course, but from the entire facility.
That's right.
From even the lowest of those that work here at the hospital. Tremendous amount of work on that issue. And it's nice to see it all laid out the way it is. Nice to see us making progress. I appreciate all you've done on that. Thank you. Thank you very much. I think it's appropriate at this point that we move our action item up in the agenda such that we can take action right now on that budget. I think it just feels appropriate to be able to take action and approve that, at least consider approving that presentation on the budget. Thank you very much for that. I'll be glad now to take a motion to consider the budget, the resolution number 1251 budget estimate for 2023, 2024.
Mr. President, I move that the board approve resolution number 1251, budget estimate for fiscal year 2023, 2024.
And do we have a second? Okay. We have a motion and a second. Cheryl, let's take.
Dr. Stewart,
I'm sorry.
I think it would be a good idea, because this is the budget, to especially note and ask if there's any public comment.
Thank you. I appreciate that,
A
Paul.
public hearing, and see if anybody wants to comment on it.
Okay, we have a motion and we have a second. I'd welcome any public comment on that motion at this point in time. It's an important item, and we'd welcome any comment or input that can be given on that item. Are there any to be heard from the public? Hearing none, then there's no further comment from board members. We'll have Cheryl take the roll on that resolution.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee. Aye. Director Epen.
Thank you very much. That motion passes, and again, congratulations to all the people that worked on that budget. That's
Yeah, I do just want to especially thank Tom and Erica. They've spent a lot of hours and a lot of time on that, but also the vice presidents and Tina and Larry and Ed have all spent a lot of time, along with our executive team and the whole management team. So I know this is something that it's taken much time, but it's also a very thoughtful budget that we've put together. So appreciate everybody's time and effort.
very impressive tonight. Thank you very, very much. We're at a point now in our meeting where we can move on to our reports. We'll be glad now to hear from Dr. Hyder on the medical staff report. Take just a minute for Dr. Hyder to make that connection. I've seen him here before, earlier. There he is. Welcome, Dr. Hyder.
Good evening. Thank you so much. Good evening to all the board members, Honorable. First of all, I want to thank all the board members for attending the dinner dance. And we really, really appreciate for that. There was a little bit traffic problem, but it went very, very well. And we addressed a lot of items, and a lot of doctors were awarded for their services to Washington Hospital. And then we have a total number of we have grand total of 592 physicians total. Out of that are active are 338, administrative are 1, advanced practice provider are 40, ambulatory is 98, consulting 7, courtesy 17, leave of absence is 3, provisional active 50, and provisional APP 24, provisional consulting 12, and provisional courtesy 2. That comes to grand total of 592. With anesthesiology are 30, family medicine 45, medicine is 268, and OB-GYN is 32, pediatrics is 60, and radiology is 27, and surgery is 130 with a grand total of 592. And I'm very thankful to the board. This might, I mean, the last report I'll be giving, because from the next month, Dr. Saleh will take over. And I really, really appreciate all the help and the guidance and for tolerating me.
Dr. Hyder, we appreciate the work you've done as the medical staff, in the medical staff. It's very, very important work. It's has many, many important ramifications throughout the whole system. And it's a position we rely on for many, many problems, for many, many situations that come up, that working with the medical staff, and we appreciate your dedication.
Thank you so much.
Your hard work in that area. We thank you very, very much for that.
Thank you so much.
It has been a pleasure to work with you. And,
thank you so much.
And I can say that I enjoyed the dinner dance also. That was,
Thank you.
That was a very nice thing. It was very interesting to see the awards given to longevity on the medical staff. That was nice. That was nice
Thank
to
you.
see.
Yeah.
Anyway,
It was something good after the COVID, you know, we went through a lot of 2 years of pandemic. Yeah. That was something.
Yes, I should have mentioned that you served us during a very challenging and difficult time. Certainly the most unusual few years that a chief of staff has been able to work in.
Yes.
Very challenging, very different.
Thank you so much.
Thank you very, very much.
Thank you. Thank you so much. Thank you.
Now move on. We'll now move on to our Service League report. Sheila is available, and we'll be glad to hear from you now, Sheila.
Good evening, members of the district board. Greetings from all the volunteers. We've been very busy this past month. For the month of May, 182 Service League volunteers contributed 2,101 hours to the hospital. We also hosted an orientation in May, attended by 5 high school students, 17 college students, and 8 adults. From May 1st through the 3rd, the Service League had its semi-annual $5 jewelry and gift sale. Shopping was steady throughout the 3 days. I'm happy to report that the commission earned by the Service League totaled over $7,000. The quilting group also had their first ever spring quilt raffle. It was a successful fundraising endeavor for them. They made over $400. In the month of May, our Mended Hearts volunteer visits went up by over 45%. They talked to 43 heart patients and interacted with 18 family members and caregivers. Last month, I spoke about my shadowing experience in the surgery liaison. This month, I'm happy to talk about my wonderful time with shadowing Margaret Peterman, a dedicated gift shop volunteer. She's been with us for quite some time. I gained a firsthand understanding of the day-to-day operations, valuable insights, and a newfound appreciation for the art of customer service. From the moment the customers stepped into our gift shop, Margaret greeted them with a smile, making them feel instantly at ease. Just to cite a quick example, a gentleman stepped in that day to buy some candy, but he got distracted by the solar garden stakes that were on display. Margaret greeted him warmly, offered her assistance, and persuaded the customer to buy the solar garden stake that he was just looking at. The gentleman left the gift shop with a smile on his face. He was happy to make his wife happy, grateful for the exceptional assistance he had received. What I liked really about Margaret was that she didn't really push the customers to buy anything. Instead, she gently introduced them to various items. So if you're ever in the gift shop, watch out for Margaret Peterman, because you will probably walk away with. On that day, during 1.5 hours, the gift shop had several customers, barring 2. All of them bought something. Really, shadowing Margaret was an eye-opening journey into the world of retail for me. The experience deepened my appreciation for the hard work that goes into volunteering in a gift shop. I expect to visit more volunteering areas in the coming weeks and bringing to your attention all the wonderful service that we provide our hospital community. It was not all work and no play for the volunteers. We had our spring social yesterday. That was fun, attended by 40 volunteers. The event featured games, food, cotton candy, which I haven't had in years, and popsicles, giving it a really fun outdoor picnic atmosphere. That's the end of my report. Now, please let me know if you have any questions.
Thank you very, very much, Sheila. Are there any questions from the board for Sheila? Sheila, we appreciate your work with
Thank you so
volunteers.
much.
I think it's fair to say that you're always looking for new volunteers.
Yes,
And that,
yes, absolutely.
and it's wonderful, really wonderful to see the recovery now since COVID. We can all remember times when the volunteers could not be at the hospital even.
And some hospitals still have not welcomed volunteers back.
No, they haven't welcomed, while we are opening more and more more and more areas where they could potentially volunteer. So
The hours that you've reported tonight are very impressive. It's a wonderful work that occurs through the volunteers throughout the hospital. Thank you very much.
absolutely, I hope our volunteering goes up just like our budget too. Thank you, Dr. Stewart.
Thank you. We're now ready to move on to our quality report. And Kimberly, could you introduce Dr. Rose?
Yes, it's my pleasure. Dr. Jack Rose is here this evening to present the annual report for stroke for calendar year 2022, and I'll just give you a short introduction of Dr. Rose. He joined Washington Township Medical Foundation in early 2014. He received his undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year critical care and stroke fellowship at the University of California, San Francisco. He is an expert in neuro-intensive care and cerebral vascular disease, and was among the first 100 physicians in the world to become board certified in neurocritical care. He is also board certified in neurology as well as vascular neurology. Dr. Rose's experience and leadership augments Washington Hospital's comprehensive stroke and neurosurgical programs, especially his in cerebral vascular neurosurgery and interventional neuroradiology. He personally provides the patients treated at Washington Hospital with the continuity of care that is critical when treating the full range of cerebral vascular conditions. Dr. Rose is co-medical director of the stroke program with Dr. Prabhat Khalsa. He is also chair of Washington Hospital's Continuing Medical Education Committee and its Institutional Review Board. Thank you, Dr. Rose, for joining us this evening. And I think I saw Dr. Khalsa there also.
Thank you very much, Kimberly, for the kind introduction, and thank you to Dr. Stewart and the rest of the board. Can you all hear me well?
Yes.
Okay, great. I'm going to attempt to share my screen to share our stroke program 2022 report. So give me 1 minute. And can you see my presentation in front of you?
Yeah.
Okay, great. So thank you again for having me present on behalf of the entire stroke program. It takes a large group of outstanding and dedicated healthcare professionals to run this stroke program, and we feel that we have an outstanding stroke program, and always appreciate the opportunity to highlight all the work that we put in the last year and share some of our outcome data with you as well. So in terms of program overview, not much has changed. This is the stroke program leadership. Larry Lavoisier has now been our executive leader for a few years now as a VP and CNO. And like Kimberly mentioned, Dr. Khalsa and I are the program medical co-directors. And together with two other neurologists, Dr. Sharon Singh and Dr. Ravi Kalan, we are the 4 program neurologists. We have Michael Platzbecker, a long-term employee and nurse leader, who is our ED and stroke director. And we have an outstanding clinical manager in Maria Nunes, who is our stroke program manager and a nurse practitioner. Our stroke program structure is the same as it's always been, but we always like to highlight it. We're one of the few hospitals or centers in the country that have dedicated 24/7, 365 stroke nurses, many of whom have national certifications, advanced training and/or degrees in neuro-related fields. We have the 4 neurologists in the program, as well as several neurosurgeons, as well as a dedicated vascular neurosurgeon, Dr. Jeff Thomas, and an additional neuroendovascular radiologist, Dr. David Carrington, who takes care of our patients. And it is a multidisciplinary team that interfaces with any patient coming to our hospital with stroke or stroke symptoms. And it starts from EMS. You see that's this orange bubble pointing at the patient. Oftentimes it starts with EMS care and assessment. And then rapidly patients come to our emergency department, where our ED staff, both nursing and physician, rapidly assess our patient, as well as the stroke nurse. And we rapidly utilize our laboratory and pharmacy teams, as well as radiology, to take quick action and get scans done, blood tests drawn, and have neurologists on call and interventional specialists on call at all times to make a quick decision and treatment choices. And once the patient is admitted to our hospital, we have dedicated stroke units and fully staffed intensive care units as needed. And we have an outstanding team of rehab professionals from physical therapy, occupational therapy, speech therapy, and we have a strong team of case managers and social workers help us with our patient disposition. All of these components working together, focusing on the care of the patient and supporting their family as well. We also have a code neuro stroke alert process, which has really helped us for the last several years to rapidly identify possible stroke patients and get their scans and diagnostic studies done in a very, very timely, rapid fashion. We have been doing this for the last several years. And it's an overhead paging system that rapidly alerts the stroke team to potential stroke patients, mostly in the emergency room, but anywhere throughout the hospital, actually. And now that we have some stroke therapies recommended to consider up to 24 hours after stroke onset, our code neuro alert is now being adjusted to potentially being called out for any potential stroke patient that has symptoms within the last 24 hours. So we're working on adjusting that slight change over the recent past. And all of this is to rapidly get patients triaged and assessed and considered for hyperacute stroke therapy. In terms of our program guidance and dissemination of our data, we continue to have monthly stroke review committee meetings, for which we have representatives from the emergency department, from radiology, our medical directors, neurosurgery, if possible, administration, and we go over all of our data of all of our stroke patients on the monthly basis. I also attend the critical care committee meeting as a representative from our stroke team, and occasionally attend the neurosurgery or vascular review committees when they do meet. We also present our programmatic data to the Quality Steering Committee. I gave that update this past May 1st, as well as we give an annual update of our program and our outcome data to the Board of the Directors every year. That's what I'm doing right now. How has our stroke patient volume been this past year and through the pandemic? Well, our stroke volume has stayed high. And in fact, has increased a little bit. You'll notice this is the stroke volume since 2008, when we first became Joint Commission Primary Stroke Certified. And through the pandemic, so towards the end of 2019 through 2020 and 2021, there was maybe a little bit of a dip, but not a significant volume dip in our overall number of stroke patients in our hospital. But since 2020, a slight steady increase up to almost 500 stroke patients a year. So we saw maybe only a small decrease in the very beginning of the pandemic, but we worked very hard to make sure that any patient that was experiencing potential stroke symptoms, even during the pandemic, knew that is an emergency that needs medical attention at the hospital and shouldn't be left for care at home or in the outpatient setting. So we're pleased with our volume increase over the last year in 2022. In terms of neurosurgery and endovascular procedures that we've accomplished over the last, in 2022, we had 9 thrombectomies. That's an advanced blocked artery stroke procedure, where a tiny catheter is inserted through the groin artery up to the blocked artery in the brain or the neck, and the clot is extracted. And so we saw a slight increase in our number of thrombectomies in 2022 compared to the last couple of years, and we're hoping to increase that volume in the future. Coiling and clipping refers to procedures that are done to treat ruptured or sometimes unruptured brain aneurysms, which is a dangerous form of bleeding stroke that Dr. Thomas and I are expert at treating. And we saw a similar number of coiling and clipping procedures done in 2022 compared to 2021, about 14 coiling or clipping procedures. Carotid stent is a stenting procedure that's done in the carotid artery for a narrowed carotid artery. And you see that the numbers are very small, and that's not because we don't have the capabilities to do this procedure. It's just that this procedure has fewer and fewer indications, and the clinical literature and research is supporting the maximal medical therapy as being a superior treatment for especially asymptomatic narrowing of carotid arteries over doing a procedure to revascularize the carotid. So that's a good trend in our opinion in terms of doing fewer and fewer carotid stents. We are continuing to participate in one of the country's largest randomized clinical trials, looking at carotid revascularization surgery versus medical therapy, together with Dr. Ash Jain, and that is ongoing, and we're very, very pleased to be one of the sites for that important clinical trial. How about our stroke program outcomes in the last year? Well, if you look across our calendar year 2022, these are the 10 major quality measurements that we have to report. And the goal is to be above the 85% mark on all of these 10 important quality measures. And these are measures that are important in terms of patient outcome, and that are tracked by the American Stroke Association through their Get With The Guidelines program. And you'll see that not only we're above 85% in all of these measures, we are at 100 in many of them, if not close to 100 in all of them. And these include things like providing stroke education to the patient and their families, giving a clot busting medicine very quickly, giving them medical and or mechanical treatments to prevent blood clots to develop in the leg, early use of a blood thinner medication to prevent second additional strokes, smoking cessation counseling, discharging patients with an intensive statin, making sure that stroke patients that have atrial fibrillation are discharged on an oral anticoagulant, screening our patients for swallowing trouble, assessing them for rehab, and making sure that we have highly detailed measures of their stroke deficits within the first several hours of admission. So we continue to do an outstanding job with all of these 10 important quality measures. And we report these measures not just on a yearly basis, but on a monthly basis at our stroke review committee meetings. In terms of our functional outcome for our stroke patients at discharge from the hospital, we are pleased to continue to report really good functional outcome measures for our stroke patients. So this upper pie chart here is showing you the functional outcome at discharge for our patients. The green, the 62% part of the chart here, that is considered a relatively good outcome at discharge, as opposed to the red, which is a worse outcome. And that translates either to a no mild or moderate disability, but with the ability to independently walk without assistance. And so at discharge, about 60% of our patients are able to at least ambulate independently without assistance. And if you compare that to all reporting California hospitals for stroke patients on discharge, that's only at about 28%. So we can, and this is some reliable data we've seen in the last few years. So we continue to report relatively good functional outcomes referable to other hospitals at discharge. And in terms of performance improvement, some of the things that we're looking at are to continue to provide the one medical therapy we have for acute blocked artery strokes or acute ischemic strokes, which is a clot busting medicine called TPA. And the goal is to provide that therapy to the right patients as rapidly as possible once you make the decision that it is safe and appropriate to give it to them. The goal over the past several years has been to give this TPA medicine within an hour of the arrival time to our emergency department. It's called the door to needle time or the door to drug time. And you see that this is the data going back to 2009. And you see that the goal with the guidelines is to be over 85% to provide this drug within 60 minutes of hitting the emergency room door. And for the last several years, including throughout the pandemic, we've been well above this 85% goal in the mid to low 90%. And so we're happy to continue that trend, but we're the organizations that champion high quality stroke care have been recommending even more rapid administration of TPA. I forgot to mention that if you look at other hospitals compared to Washington, we're the green, other hospital primary stroke centers, just like ours, in terms of reporting TPA administration within an hour. We have been steadily reporting higher percentages of patients receiving that clot busting medicine within 60 minutes compared to other hospitals. But we don't just want to stop to be faster than 60 minutes. Get with the guidelines in 2019 came up with a more aggressive goal of getting about to 75% of the patients getting this drug within 45 minutes of hitting the emergency room door, which is has been a challenge, but we're happy to be close to that goal now. You'll see that in 2022, we were at about 64%, which is approaching that 75% goal, whereas in years past, we were nowhere near that 75% goal. But if you compare that to other primary stroke centers, we're similar to other hospitals in meeting that, not quite meeting that 75%. So not many hospitals are achieving that aggressive goal yet, but we're working hard to try to do that. The latest target stroke goals and recommendations from the American Heart and Stroke Association has been to continue that 75% less than 45-minute target, as well as even trying to get 50% of the time patients treated within 30 minutes, which is an extremely aggressive but laudable goal to target. And we recognize that if we were having trouble with getting less than 45 minutes, it would be quite challenging to do that in less than 30 minutes, but we wanted to do our best and see what we could do to try to reach that goal. And so we had to think a little bit out of the box, and actually with the help with our pharmacy team who spearheaded us to start thinking about, well, do we have to give this the exact same TPA formulation that we've been giving for many years? There is an alternative TPA medicine that certain hospitals and stroke centers throughout the world and in the United States have been using instead of the standard alteplase, which is the formulation of TPA we've been using for many years. There's a cousin medicine, a different type of TPA called tenecteplase, and there are many potential benefits of using that drug as opposed to the one we've been using for the last several years. So we worked with the pharmacy group and we worked with our whole stroke program to think about changing our TPA formulation. And we came up with a plan to replace alteplase with this newer tenecteplase, or at least newer for use in stroke. And the difference with this drug is that we can actually house this drug in the ER. It doesn't have to be housed and mixed up in the pharmacy. And so that decreases the time used to mix it and to provide it to the patient, and can be given very quickly by the stroke nurse or the ED nurse. Also, the nice thing about this drug is that it's given as just an IV bolus. You do not have to give an hour infusion like the other alteplase TPA that we used to give. And so we did a lot of education about and thinking about why we would do this switch. And everyone agreed that it would be worth trying. It also happens to have cost savings associated with it. And importantly, the clinical literature has supported that it's just as efficacious, if not better, than the older alteplase with a very, very similar safety profile. So we don't anticipate seeing worse outcomes and maybe even better outcomes, despite, in addition to giving this potentially drug faster to our patients. And so we came up with a performance improvement plan for achieving some of our faster TPA administration goals, highlighting the switch from alteplase to tenecteplase. And the go live date, I forgot to mention, was April 7th. So a little bit more than a year ago, we made the switch. And how have we done since then? Well, this is our door to needle time broken down by quarters. The first 4 are the quarters of 2022, door to needle time of the new TPA, starting in quarter 2 of 2022 and up to the first quarter of 2023. You see that we are at 90 now to 100% of our TPA administered patients getting it within an hour. If you look at door to needle time within 45 minutes, once we made the switch, which is quarter 2, 2022 to the last 3 quarters, you see that now we've achieved 2 quarters above that 75% goal, which we were never able to achieve before, which we're very happy to see. And then the door to needle time, trying to get up to 50% within 30 minutes, which we were never close to doing before until we made the switch to our new TPA, our tenecteplase. For the last 3 quarters, we've been at 50%, and our first quarter of 2023, we were at 100%. Getting our TPA within 30 minutes. So this is a tremendous achievement, and we're very happy to see this trend. There should be some fluctuations, but overall the trend is very positive, and our clinical outcomes and safety profile with the new TPA drug has been very favorable. So we're very happy we made the switch, and it's been a strong effort of multiple people that has made this a successful switch and a great performance improvement project. One of the other performance improvement projects that we've been tracking is to make sure that stroke patients that are blocked artery stroke patients get discharged not just on a statin, a cholesterol lowering medicine, but a particular intensive dose of a particular statin. And you see that in 2029, we were only at about 56% of our patients getting an intensive statin when it was indicated, with the goal being above 75%. And in the last 3 years, we've gone above that goal, and in 2022 we were almost at 100% compliance with appropriate patients getting intensive statins at discharge. So we're happy to see that that trend and meet that goal. Other performance measures we're tracking and continue to track are rapid reading of CT scans within 45 minutes. So this is not just getting the scan done, but having the official reading in the chart from the radiologist within 45 minutes. And we do a pretty good job of that. We're the green bars here. This is over the last 3 years compared to the other primary stroke centers being the red bar. So we're very similar to other hospitals in achieving this goal, still not at 100%. And if you ask why 10% of the patients don't get this CT reading in the chart within 45 minutes, we also we analyze why these fallouts are happening. the bulk of these cases are patients that show up in our ER with atypical stroke symptoms, just a little bit of dizziness, just a little bit of mild headache, just a little bit of nausea, not your typical stroke symptoms, or that we have problems with delayed from our after hours teleradiology report showing up into the system. So we work hard to analyze these fallouts every month. We analyze them by a case-by-case basis and do what we can to try to educate the ED staff, as well as work with our radiology group to make sure that any kind of delays from teleradiology can be minimized as much as possible. In terms of getting our ED physicians to assess potential stroke patients very rapidly within 15 minutes of hitting our emergency room door, we're also very similar to other hospitals in 2022 in the last couple of years, but still similar to other hospitals. There's about 30% of the time that our physicians take a little bit more than 15 minutes to assess the patients. And again, these fallouts are in patients that are not considered acute code neuro patients. These patients come up with atypical symptoms, and that's why they're not seen rapidly. But we continue to educate and work with our ED group to try to minimize these delays in ED assessment. In terms of blood glucose, which is a key measure and safety measure that we need to have in the chart before we consider giving the clot busting medicine. There's a higher chance for having a brain bleeding complication if your blood glucose happens to be really high and you get TPA. So it's very important we know immediately what the blood glucose level is. And if you look in 2022, we have a point of care testing blood glucose result 95% of the time very rapidly. And if you compare that to other hospitals, we do quite a better job at getting that early blood glucose level in the medical record and to the attention of the physicians as soon as possible. We also track how our stroke patients show up. What percentage of the patients show up by ambulance, via 911, for EMS activation, and what percentage are walk-in patients that come into the hospital driving themselves or having a family member bring them in. Obviously, we want to educate patients, family, and the public to call 911 and bring potential stroke patients in via EMS to rapidly get them assessed safely and quickly. Over the last few years, our numbers have still been about 50-50. So we still see about 50% of our patients coming in by EMS, 50% being walk-in. So that was especially a challenge to get that education out during the pandemic, but we continue to try to increase the public's awareness about why you should call 911 for potential stroke patients and not bring the patient in as a family member or bring yourself into the hospital if you suspect that you or one of your loved ones, your family member, or even a bystander is showing signs of a stroke. And so we continue to try to educate that is the best way for patients to be brought into the hospital. But we're still at about that 50-50 mark. How about patient satisfaction data? We know we have good outcomes. We have a very strong stroke treatment team. How are our patients reporting the satisfaction with our program? Well, one of the things that we did in the last several years was that we engaged and hired a third-party company called MedTel, and they are a company that specializes in getting patient satisfaction follow-up data through telephone calls, both at 7 days and 90 days after hospital discharge. And this is not just something that we wanted to do as a high quality sort of follow-up project, but it is a Joint Commission requirement that we get follow-up data on our stroke patients, especially as we move towards higher levels of Joint Commission certification. We need functional outcome data within 90 days. And so this is a great way for us to get this information. And some of the questions that the patients or their family are asked when they get those phone call at 7 days or 90 days is questions related to their functional abilities, whether they followed up with their primary care doctor, whether they're taking their medicines, whether they know what risk factors for stroke are, and how can they identify stroke warning signs, et cetera. And we've been very happy with this company, and we've been getting a very high yield from our stroke patients reporting these follow-up information to them. And we report this on a monthly basis to our stroke review committee. One of the things that we noticed was that only about 50% of our patients had seen their primary care doctor after discharge for a stroke, and we felt that that was lower than we would want. And so one of the performance improvement plans we did because of this follow-up patient satisfaction or outcome data was to create a discharge flyer to highlight the benefits and importance of seeing your primary care physician within a week of hospital discharge, or at least making that appointment to be seen as soon as possible. And so this was the PI plan that we developed to create this flyer to improve the percentage of patients seeing their primary care within a week of discharge. You see that before we started this performance improvement plan, the compliance with seeing their primary care physician within that week was only at about 50 to 60%. But after we developed that flyer and really worked with our stroke nurses and our other nurses to really highlight this important follow-up piece of information, more recently we've seen outcome data closer to high 70s, even low 80s percentage of our patients following up with their primary care within a week. So we're very happy to see that trend and hope that it continues. In terms of staff education about our stroke program and the latest stroke therapies and procedures, I present a neurovascular or stroke case series monthly over Zoom. It continued during the pandemic on Zoom. In fact, I gave a presentation this afternoon, and it's attended by physicians, by nurses, by rehab staff, and it is well attended. And there's continuing medical education and nursing contact hours available for this educational program. We go over at least three interesting stroke cases every month. We also discuss the latest trial data and treatment guidelines and all of our programmatic information, like I've been mentioning, at our monthly stroke review committee meetings. We also have ED nurses neuro huddles and code neuro simulations, especially for our new stroke nurse hires, to really make sure that they're comfortable with rapid code neuro assessment and triage. And one of the great things that we've done during the pandemic is to make sure that we have iPads in the hospital that allow stroke nurses to rapidly show televideo connections to the on-call neurologist to help with rapid decision-making and TPA stroke treatment, no matter what time of the day it is. In terms of patient education, we continue to highly focus on making sure patients and or their families understand what a stroke is, why they particularly had a stroke, what they can do to rehabilitate themselves, to treat their related conditions like diabetes and hypertension and hypercholesterolemia, and to understand why we're giving them certain medications and to individualize their plan of care, make sure that they understand why they're getting prescribed these certain medicines and why they need to have these particular type of lifestyle adjustments to minimize the chance of them having a future stroke and to maximize the recovery from the stroke they just had. We also work towards educating the community. We interface with EMS. We join quarterly meetings with our local EMS and occasionally present our data with them. We quarterly submit our stroke program data to our EMS as they do to us. And we offer education to our EMS colleagues as well. We also have a strong stroke support and survivor group here. Used to meet in person. During the pandemic, we had to temporarily halt that, but then we resumed that over Zoom, and that is now back up and running and still held over Zoom. And it's an important thing that we provide for our stroke survivors for stroke support for family members and survivors of stroke. In terms of additional community education, we continue to support publications and use outreach through our stroke education series, occasionally give presentations at assisted living facilities. We have done a couple of Facebook Live presentations. One was on signs and symptoms of stroke, and then another on life after stroke. We also we do an annual stroke awareness article in our Tri-City newspaper. In terms of our 2022 achievements and goals, we achieved Get With the Guidelines Gold Plus Award and Target Honor Roll for diabetes. Like I showed you, we decreased our median time of TPA administration by switching our formulation, and very happy to see improvements in how rapidly we can safely and effectively give this drug. We are also looking and have worked hard to expand our services to beyond the Tri-City area, beyond our Fremont border, especially with neurosurgical vascular patients like brain aneurysms that Dr. Thomas and I can take care of, to bring in outside hospital patients. And we're working hard together with the entire neuroscience program about augmenting our marketing strategies to bring in more patients that we feel that we could treat extremely well at Washington. In terms of our program goals for 2023 and 2024, we're continuing to track our rapid administration of TPA and to work towards making sure we can achieve that target as well as we have been doing. We're looking towards making sure that we're providing advanced neuro IR treatments for certain large blocked artery patients that have stroke that would benefit from doing a neuro cath lab procedure. Our window for that in certain patients for severe strokes has been extended to 24 hours. And we have very advanced neuroimaging studies to help us decide which patients may be a candidate for that. And we can do this procedure at any time. And we're looking forward in the future to becoming certified, not just recertified for primary stroke, which we've been for many years, but also towards advancing towards thrombectomy capable or even comprehensive stroke certification in the future. And lastly, just the last slide is to reiterate that everyone we hope understands what a stroke is and to recognize the signs or symptoms of stroke and to use this BFAST mnemonic. BFAST stands for balance. So if you suddenly have a problem with your balance, suddenly can't walk. E for eyes, if you suddenly lose vision in one of your eyes or have a darkening in one of your eyes, or suddenly have double vision, consider stroke. F for face, if suddenly one side of the face is drooped, that could be a sign of a stroke. If A for arm, if suddenly you have loss of sensation or usually more often a weakness of one of your arms or leg, then that is something that is a symptom of a stroke. S for speech, if your speech is suddenly slurred or you cannot understand speech or communicate, that could be a sign of a stroke. And T for time, you need to, many of our treatments for stroke are very time dependent, and we need to assess you and potentially give you a stroke treatment within a few hours of onset. And so if you recognize any of these symptoms in yourself or your family, friends, or even in someone sitting next to you at the coffee shop, you want to call 911 immediately and bring them to a stroke center such as Washington Hospital. And if anybody wants more information about our stroke program or stroke in general, you can visit our website, whhs.com/stroke. So thank you very much, and be happy to answer any questions if anyone has.
Thank you, Dr. Rose. It's very, very impressive. What a wonderful service for the citizens of the district to have that so available, and not only available, but very, very effective. Just such a terrible thing to see the results of an untreated or slowly treated stroke of some sort. It can be a lifelong disastrous situation for a patient. Gee, that's exciting to see what you've done and exciting to see what's possible and what you're doing there. Thank you very, very much. I'm not ready to test out the program.
No, thank you very much, Dr. Stewart.
Are there any other questions or comments from the board?
I want to say thank your team for us.
Absolutely. It takes a huge number of people to accomplish what we've accomplished and continue to provide the highest quality care for a stroke patient. So there's so many people that I can't thank by name, but it's a huge team, and appreciate all the administration and the board of directors' help in making sure we have the appropriate staff and technologies and budget to do such an important service. So
I think the time to administration of medication is remarkable. Truly is.
Yeah, we're very happy to see that. I mean, we were worried that we were going to have a really hard time improving what we originally thought was a really good data that we had referable to that, but switching our drug formulation has really been an excellent idea and has had really good effects so far. So.
Thank you. Thank you again. Very, very interesting and informative for us and for the community. Thank you very much. Now, Tom, we're ready for more finance.
All right. Well, my pleasure to present the operating statistics for the month of April 2023. There we are. Inpatient average daily census of 141.4 was below the budget of 152.4 by 11 or 7.2%. Our combined average daily census of 150.8 was below the budget of 163.3. by about 7.7%. Admissions were above budget, 806 to a budget of 788 for a 2.3% increase over budget. And as patient days, we had 4,242 were below budget by 329 or 7.2%. Outpatient observation equivalent days were at 281, below the budget of 329 by 48 days. Average length of stay of 5.17 was below the budget of 5.8, or 0.63, about 11%. We had 7 discharges with length of stay greater than 30 days, ranging from 31 to 72. If we were to exclude those 7, our average length of stay was 4.9. Next slide. The CMI for April was 1.563, slightly under budget by 0.064. Deliveries for April were 115, just below budget by 5. Total surgeries of 340 were below the budget by 9, or 2.6%. And cath lab cases at 150 were 79 below budget, or about 35%. Non-emergency outpatient visits of 8525 were below budget by 53. So pretty break even on that one. And emergency room visits of 4727 were above budget by 258. So consistent story in the ED with just outperforming the budget. Next slide. Well, you're fast. Okay. This is just a breakdown of the numbers from earlier. We had 340 total surgical cases, and you'll see that even though we had some movement of our joint replacement cases to the ambulatory surgery center, the volume has stayed consistent within the hospital at 161 compared to 139 on the budget. The neuro and cardiac have struggled over the course of fiscal 23. April is no different, but those are the 2 programs we mentioned earlier that are a focus for fiscal 24. The cath lab has been consistently under budget for the fiscal year, and again, this is due to a departure. And as we mentioned earlier in the meeting, we have hired additional physicians to pick up the volume on cath lab. Productivity measures. Productive FTEs were above budget by 1.9, so pretty much on budget. Non-productive FTEs were above budget by 37.6, or 21%, as we did see a lot of ETO during the month of April. Total FTEs of 1616 were above budget by 39.5. Total FTEs for adjusted occupied bed of 6.19 were lower than the budget of 6.31. And total FTEs of 1616 were above the flex budget of 1546 by 70. So total deductions. Gross revenue of $183.2 million for April, below budget by $7.8 million. Inpatient gross revenue of $99.3 was below by $17.3, while outpatient gross revenue of $84 million was above budget by $9.5, or 13%. The payer mix for April was not favorable, driving contractual allowance higher than budget. Government-sponsored patient revenue made up 72.1% of total gross revenue, and this was higher than the budget of 71.8. However, private pay was 1.4% of gross revenue, which was lower than the budget of 1.6, thus resulting in the positive variance in the provision for bad debt and charity. Here we have the GASB format for the summary of operations. Patient revenue at 183.2, as I just mentioned, was 4.1% higher than the budget, or excuse me, lower than the budget due to lower volumes. Due to bad debt being lower than budget, the overall deductions as a percentage of revenue at 76.83 were lower than the 77.04 that was budgeted. Including other revenue, total operating revenue is at 46.3 million, was 4.3% higher than budget. Operating expenses at 46.1 million were 3.6 million, or 88.4% higher than the budget, and that was primarily labor costs. Salaries remained unfavorable at 16.3%, and employee benefits were unfavorable by 9.4%, as we saw higher medical claims during the month. This resulted in an operating income of $242,000 and a positive operating margin of 0.52 for the month of April, which was unfavorable compared to the budgeted income of $1.9 million. In April, we had $685,000 in non-op income due to unrealized investment earnings in the month. We ended with a net income of $927,000 and a fiscal year-to-date net income of $8.7 million. Next slide. So this is the same report, but in GASB. And in GASB, as a reminder, we pull out the interest expense and the property tax revenue. The slide reflects the same information, but the thing I'll point out here is the 0.2% total margin for the month of April and 1.1 year-to-date on the total margin compared to the GASB that had us at 1.9. Which brings us to the EBITDA slide. So are we generating cash? In the month of April, we had an 8.3% EBITDA margin, generating around $3.9 million in cash. Year-to-date, we've generated 42.7 or 9.4% EBITDA margin. And with that, I will turn it over to Kimberly.
Are there any questions on April before we move to May?
No.
All right, I am going to present May 2023. As you can see, gross revenue of $202.9 million for May was above the budget by $19.5 million and was above May 2022 by $5.6 million. Inpatient gross revenue of $112.3 million was above the budget by $4.5 million or 4.2%, but was $4.8 million or 4.1% below May of 2022. Outpatient gross revenue of $90.6 million was above the budget by $15 million and $10.4 million above May of 2022. In May, the Radiation Oncology Center had $3.6 million in outpatient revenue. And also there were 35 adult COVID-19 discharges, 4% of the total discharges. And this was a decrease of 3 cases from the prior month. Moving on to key census statistics. The average length of stay of 5.3 was below the budget of 5.52 by 0.22 or 4%, and this was lower than the May of 2022 average length of stay of 5.67. There were 9 discharges with length of stay greater than 30 days, ranging from 31 days to 82 days. Excluding these outliers, the average length of stay was 4.86. And still in-house, at the end of the month, we had 6 patients with the length of stay over 30 days. They range from 34 to 53. So continue to work on that length of stay and making sure patients are in the appropriate level of care. Looking at outpatient observation equivalent days at 313, they were below the budget of 320 by 7 days or 2.2%. Inpatient average daily census of 146.8 was above the budget of 134.9 by 11.9 or 8.8%, and then the combined average daily census of 156.9 was above the budget of 145 by 11.7 or 8.1%, but was 4.7 below the May of 2022 average daily census. Looking at our admissions, admissions of 887 were above the budget of 758 by 129 or 17%. May 2023 admissions were 3.6% above May of 2022. And the favorable variance was mainly driven by medical cases. Also, again, as Erica referenced in her presentation, we're looking at discharges, and they were 18.5% higher than budget at 898 for the month. And again, this is a new slide that we're going to start to use starting at the beginning of the fiscal year. And in healthcare, we do monitor the discharges as an additional key indicator. And so we really want to do that because it really ties to our average length of stay and case mix index. Moving on to patient days, the admissions are higher than expected, resulting in patient days of 4,550. This is above the budget by 368 or 8.8%, and 165 days or 33.5% below May of 2022. We saw adult med-surg days were higher than budget by 270 days or 9.3%. OB, peds, and special care nursery days were higher than budget by 103 or 23.9%. And as we've seen in the past, there was a shift in ICU days and IMC days. Our intermediate care days or intermediate care or IMC days at 398 were higher than the budget of 318 by 80 days, but ICU days were lower than budget by 84 days or 16.2%. Looking at our surgical trend, total surgeries in May of 394 were above the budget by 36 or 10.1%, and were 2.6% above May of 2022. Our inpatient surgeries at 136 were above the budget by 4 or 3.3%, but 8 or 5.6% below May 2022. And outpatient surgeries at 258 were above the budget by 32 or 14.2%, and 7.5% above May of 2022. Here you can see the breakdown of our surgical activity as mentioned in last month. Our cases, joint cases, even though we've continued to see the shift to our ambulatory surgery center, they were above budget by 44 or 30.3%, and 16 or 9.2% above May of 2022. We did have 67 cases that were done at the Peninsula Surgery Center in May. Neurosurgery cases were slightly below budget by 13.8%, and you can see cardiac cases were also below budget by 26.7%, and all other surgical cases were consistent with budget at 169. Our cath lab trend, you can see we did better, but still below budget. Came in at 182 that were 40 or 18% below the budget of 222 and 7.1% below May of 2022. Our inpatient cases at 104 were 11.9% below the budget, and outpatient cases at 78 were 25% below the budget. And again, as we've talked about, we have been working on recruitment of both IR, interventional radiology, and vascular surgeons that we hope to be starting in the next few months. Looking at the breakdown of the cath lab activity, you can see cardiac cases were below the budget by 23 or 21.5%, and were 14.3% below May of 2022. Our non-vascular IR cases were below the budget by 34 or 50.7%, and were 42.1% below May of 2022. We did see in peripheral vascular cases were higher than budget by 19 cases or 46.3%, and higher 71.43% higher than May of 2022. So we did have both vascular and our vascular surgeons were very busy, and also Dr. Lin was also busy this month in May. And our neuro IR cases were below the budget by 2 or 28.6%, and were 1 below May of 2022. Deliveries, as we've noted in the past, we continue to see deliveries go up and down. We had a very busy month with May. You can see we had 144 deliveries, which were above budget by 26 or 22%, and 9.9% above May of 2022. Looking at our non-ER outpatient trend, visits of 9,258 were above the budget by 554, or 6.4%, and above May of 2022 by 602, or 7%. Really, in terms of driving the volume, we had X-ray visits that were 9.3% above budget, along with cardiac rehab visits that were above budget by 30.8%. And infusion center continues to be busy, and we're up 151 visits or 33.7%. And really, this was partially offset. As we've mentioned, we no longer have the requirement to do COVID testing before any of the procedures. So our lab visits were down 431 or 11.2%. We also had radiation oncology that began to operate, as we said, in February, and there were 365 visits in May that were for. Once again, looking at our emergency room visits, they continue to be high. We saw 5,147 visits that were, and this was above the budget by 664 or 14.8%, and 8.2% above the prior year. Moving on to looking at our gross revenue recap, again, tied very much to our volume numbers. Surgical cases were above the budget by 10.1%, and revenue was also above budget by $1.3 million or 3.5%. It was somewhat lower than the volume given the reduction of the cardiac and neuro cases not being at the budget number. We did have room and board revenue that was above budget by 6.9%. Patient days were higher than budget by 8.8%. However, as we've talked about, ICU days were lower than budget by 16.2%. Deliveries were above budget by 26 or 22%, and revenue was above budget by $963,000 or 28.8%. We did have C-sections that were higher than budget this month. Our emergency room visits were above budget by 664 or 14.8%, and the revenue was above budget by 19.1%. We did see a higher level in May of level 5 and level 6, so more complex visits, acuity basically coming through the emergency room. Our cath lab visits, cases I should say, were below budget by 18%, and revenue was $466,000, 3.4% lower. We did see more procedures, and we had a few late charges from the previous month. Lastly, ancillary services revenue was above the budget by 15.5%, and this was driven by the increase in outpatient activity, as well as $3.6 million from the Radiation Oncology Center, which is now a hospital department. Looking at our payer mix, we continue to see some challenges with the payer mix. Government-sponsored patient revenue made up 71.4% of total gross revenue. It was higher than the budget, just 71.3%, but lower than the prior year's percentage of 73.5%. HMO was 2.4% of gross revenue, which was lower than the budget of 2.6%, but higher than the prior year's percentage of 2.3% of gross revenue. PPO was 23.6% of gross revenue, which was lower than the budget of 24.5%, but again, higher than the prior year's percentage of 21.7%. Lastly, our private pay was up at 2.6% of gross revenue, which was higher than the budget of 1.6% and higher than the prior percentage of 2.5%. We did have a small number of cases that made up 30% of the total private pay there. Looking at our productivity indicators, our productive FTEs for the budget were above the budget by 141 or 10.7%, at 1,457.3. Non-productive FTEs were above the budget by 19.6 or 13.3%, and 167.5. So total FTEs of 1,624.8 were above the budget by 160.6 or 11%. If you look at our productive FTEs per adjusted occupied bed, it came in at 5.49, which was lower than the budget of 5.73 by 4%. So we did do a pretty good job of being able to flex and to the increase in the volume. Also, total FTEs per adjusted occupied bed of 6.13 were lower than the budget of 6.38 by 4% or 0.25. So if you look at the total FTEs for the flex budget, we were over by 3.7%. All right, moving on to the outpatient statistics. For the Whitman clinic visits, they were below budget in May by 19.7% at 16,250. This is driven by a few pieces. The first, again, we're no longer in terms of having the COVID vaccine visits. This was down 1,182 visits. Also, we did have a number of primary care physicians and specialists that took vacation days during that time, and we are also had 3 open specialty positions that had been in the budget that we were still recruiting for during this time. So between those 3 areas made up the difference in terms of being majority below budget. If you look at our DevCo units, our outpatient visits of 2,269 were above the budget by 156 or 7.4% for May. And you can see in terms of the increases from budget for the rehab center was up 9%. The surgery center was up 1.5%. But for Peninsula Surgery Center, the visits were below budget by 35 or 34.3%. As you know, it took us some time to get all the contracts in place. And then Ohlone College visits were above budget by 52. All right, moving on to key financial statistics, you can see that days cash on hand, we did drop to 146 days, and those 6 days, dropping the 6 days from the prior month. And really, this is mainly due to the impact of having 3 pay periods instead of 2, and that is what equates to that 6 days. Also, days in accounts receivable in May were at 57.3. This is lower than the prior month by 1.5 days, and 7 days lower than the May 2022. So there were $445,000 in charity care adjustments for May of 2023. So we had a busy month, but we did have some challenges in certain areas in terms of seeing where we end up for the month. Should I move on to just doing the calendar? Are there any questions? I'm sorry.
I think we're ready if there aren't any questions from the budget. Thank you.
All right, then moving on to our hospital events reports and calendar. I do want to start with the employee of the month, Kelly Ann Toscano. She's a senior radiation therapist at the Radiation Oncology Center. And caring for each patient with knowledge, kindness, and compassion is how Kelly describes our patient-first ethic. She's been caring for patients at Washington Hospital's Radiation Oncology Center since September of 1991. In her 30-plus years of experience, Kelly has developed a personal rapport with many patients. She says because our patients see us for several weeks at a time, we have the opportunity to get to know them and learn about their families. Many times after treatment, patients will stop by to say hello or just to see how they are doing. It's rewarding to be part of all of this wonderful team. Tammy Tyson, the Director of Oncology, notes that Kelly did not hesitate to go above and beyond to ensure exceptional patient care when our patients temporarily needed to receive treatment at the UCSF Mount Zion campus. Kelly traveled to San Francisco to visit the campus and made sure that the care for our patients was safely transitioned. Recognizing the situation could be stressful, she wanted to be certain patients saw a familiar face. Kelly works collaboratively with the entire UCSF Washington Radiation Oncology Center team. She says the team works well together, and from the day she interviewed more than 30 years ago, she noticed how nice everyone was and how well they got along. Though she was recruited by several hospitals, this collaborative spirit spoke to her and has continued throughout her career. A lifelong sports fan, Kelly and her husband, Brian, raised a daughter, Alexa, who plays competitive softball. They enjoy going to the sporting events and rooting for local teams. So congratulations to our June Employee of the Month. And lastly, just want to go through the calendar of events for the month of May. Get it up here. As you can see, May 5th through the 22nd, there were a number of events that we attended. Everything from the Special Olympics at James Logan High School, where more than 524 athletes attended. We also, Maria Nunes, as Dr. Rose talked about, has been out talking about stroke prevention. She did it at the American Business Women's Association Pathfinder chapter. We also celebrated and hosted the Celebration for Life. Our cancer survivors, friends and loved ones attended, and over 70 people attended. And you can see Lena Wang was provided diabetes education at Acacia Creek. Moving on to June 3rd through the 14th, also very busy in terms of tattoo removal clinic. We had 28 that were served. Dr. Prasad, our OBGYN, talked about the HPV vaccine on Facebook, had 26 live views and 139 accessed later. Also a number of other education that we did, from fall prevention to aortic stenosis. And also Dr. Patricia Tenhold, a pediatrician, talked about feeding your baby during the first year, and that was on Facebook Live and YouTube. You can see some of the pictures from Special Olympics and also the diabetes education. Celebration of Life, as we talked about, that Washington hosted. And then also, in terms of upcoming, we do have the Fremont Concert Series that is coming, and it will be held June 29th through August 10 at the Central Park Pavilion at Lake Elizabeth. Do want to recognize Dr. Diane Martin. She was given the 2023 Ramos Cerruti MD Award as Physician of the Year at the Medical Staff Dinner Dance that Dr. Hyder talked about on June 10th. She's very much well-deserving, and especially has made a huge impact to the healthcare system through all her work during COVID and from many years at the healthcare system, and so she was recognized for that. Also, just wanted to mention that on May 30th, the Joint Commission did 4 days, beginning of that day, did a 4-day accreditation survey at the hospital. It was unannounced, and they do come every 3 years. And we had a very good survey. We received our survey final report the other week, and we had no conditional findings. And at this point, we just have to provide them with our plan, and that we should be receiving the full accreditation from Joint Commission. And do want to thank everybody throughout the healthcare system that played a role in ensuring that we did have a successful accreditation survey. As you can see, some of our district board members attended events in the community. May 20th, there was a swearing in for Alameda County County District 2 Supervisor Eliza Marquez, and also, you can see Dr. Stewart attended that, and the Fremont Chambers city address delivered by Mayor May. Also, a number of board members attended. Also, we had talked about last time, we had the hospital and nurses week, and really it's our pleasure to honor all of our staff and nurses during this really important week, and had a number of food trucks that came and provided food to the healthcare system, and really it's a chance to say thank you to all the staff and what they do for our patients and our community. Also, just want to let the board and the community know that we did have on May 4th our golf tournament, and also had bocce ball. We did raise over $77,000 from the event, so all of that will go to surgical services, and really want to thank our platinum sponsors, Fremont Bank and Gonzalez and Kozichenko. We also will be hosting on June 21st at 5 p.m. Free charitable giving and estate planning seminars in partnership with, one of the attorneys at Hopkins Carley. And lastly, just want to make sure everybody puts it on their calendar, the 37th Top Hat Gala, scheduled for October 14th, and it will be, we will have a garden reception, an elegant sit-down dinner, and great entertainment. So just want to remind everybody about that, and those are the events coming up.
Thank you, Kimberly. Thank you
Yep.
very much. We've reached the end of our agenda for this evening, and there being no further business or action items, this meeting is adjourned.
Wow.
I figure, it's been there, I figured I might as well use it.
Wow.
Wake everybody up.